Thanks for joining us today for another coronavirus video with Contagion. Today, we're joined by Dr. Hollis O'Neal, who is a pulmonary and critical care expert at Our Lady of the Lake in Baton Rouge, and he is the National Primary Investigator for the Cytovale Early Sepsis Detection System. Thanks so much for joining us this morning.
Happy to be here.
Great. So why don't we get started and talk a little bit about, what is the current burden of sepsis in the United States?
Sepsis has gotten a lot of press over the last several years in the United States for a lot of reasons. Number one, the economic burden is really astronomical. Yearly, sepsis costs tens of billions of dollars and rapidly kind of outpaces the other costs of inpatient conditions that we have in the United States. I believe osteoarthritis, so hip, knee replacements and things like that would be probably a number two, and really sepsis massively outpaces that. The other burden that we've seen with sepsis are a couple of things that aren't really captured in monetary cost. And one is the intellectual burden it places on emergency medicine providers. It's something that they screen for constantly. There are sepsis alerts because the government has in place the SEP1 bundle that requires rapid identification and treatment. And so it really places a large, I would say, intellectual burden on the emergency department staff to identify the disease. There are frequent notifications from the electronic health record that requires them to intervene. The other burden that it places on us that is also not accounted for in costs, and the Infectious Disease Society of America has made a good point of looking at this, is the fact that because sepsis is a disease that requires emergent aggressive intervention, there's the thought that it requires early and aggressive and almost indiscriminate use of broad spectrum antibiotics, because we don't know what the organisms are going to be until sometimes several days after the patient's admitted. And so it runs the risk of promoting one of the things that we try to prevent, which is antibiotic resistance and now the development of multi-drug resistant organisms because of our indiscriminate use of broad spectrum antibiotics and the resource utilization that it requires. When we think a patient has sepsis, we often go down a pathway of early and aggressive IV fluid resuscitation, admission to the intensive care unit, and this places yet more burden on the healthcare system.
So how can sepsis come into play in patients with COVID-19?
COVID-19 has presented to us a little bit of a challenge in that traditionally we always thought of sepsis as being predominantly a disease caused by bacterial pathogens and then occasionally fungal pathogens in certain populations. What COVID-19 has really shown us is that viral pathogens can also cause a sepsis syndrome as well. It's a little bit different in that there's no great treatment for it. There's no proven therapeutic option for COVID-19 right now, or for that matter, most forms of viral sepsis. But this is, to my understanding, the first time probably in history where a viral pathogen has become the overwhelming cause of sepsis, or at least concern for the overwhelming cause of sepsis in our healthcare system. And it's really provided quite the challenge for us in discerning those patients who do have the disease. I think that one of the things that providers have a hard time understanding sometimes is that COVID-19 tends to be a +1 disease, not an instead of disease. In other words, patients will come in with all of the other things that they typically come in with, and they could have COVID-19. It's not a mutually exclusive disease. So when they come in with the disease, it's not necessarily the only thing they have. They can still have all of their other conditions and complications that they have. And so COVID-19 has really provided quite the challenge there. The other thing that it's done to us is really pressed our resource utilization. It was a disease, a pathogen that humans had never seen before, and a disease course and a natural history that was unknown to the treating clinicians. And so there was a lot of uncertainty up front in how to treat the patients. There's a lot of concern with communicability of the disease. That places a large burden on the use of personal protective equipment, and also disposition. These patients deteriorate rapidly, so they often are placed in intensive care units probably earlier than most patients would be, and for good reason, because they do deteriorate and decline so rapidly. And so, for example, an institution like ours, we increased our ICU bed capacity from 80-something beds to over 170 beds within just a week or two to accommodate the massive influx of critically ill COVID-19 patients that we have.
So Dr. O'Neill, can you tell us a little bit more about the pilot study that you're launching?
Yeah, I can. So one of the things that we've noticed and through my work with Cytovale over the last 5 to 6 years that we've seen is that the signature that occurs in viral sepsis does appear to be very similar to the signature that appears in bacterial sepsis. Um, our our largest experience with, I would say, viral sepsis over the last several years has been influenza, because that does tend to be the viral pathogen that we understand the best with regards to causing multisystem organ failure. And we found through our studies that influenza related sepsis does have a similar signature to other bacterial related sepsis. And so um, as we're thinking through this, one of the important things that we have to do in the emergency department is risk stratify patients and find those patients who are at risk for deterioration for admission to the hospital and admission to the ICU versus finding those patients who are at lower risk for deterioration. And those patients can go home and self-quarantine and treat themselves at home since there is no specific therapy for the disease. So we've designed this pilot to be placed very early in the course of an emergency department setting. So most patients who come into the emergency department with some suspicion that they may have COVID-related disease are going to be triaged, and at some point they'll probably have a purple top tube drawn for what would be a typical of a complete blood count, a CBC. We've designed this pilot to take the remnants of that CBC and then observe those patients over time and then determine if they have any infection, including COVID-19, because remember, COVID-19 is just one more of a number of pathogens that these patients could have. But we're looking to see if they have an infection such as COVID-19 and to see if the results of the test will correlate with the severity of illness that the patient has, where they're admitted to, how long they're in the hospital, do they survive, what kind of treatment do they require, what kind of IV fluids do they require. And so the goal of this study is to identify those patients rapidly and see if the results of the assay could help in risk stratification of these patients very early in the course of the disease, so that the emergency department can then rapidly work through this massive population of patients that they're seeing every day and appropriately triage them to treatment.
Now, are there any other goals or objectives that you're looking at in this trial specifically?
Yeah, there are a number. Number one is appropriate risk stratification of these patients, but number two is looking at the results of the assay with regards to the severity of illness, predicting certain things like organ dysfunction, organ failures over the first 3 to 4 days of hospitalization in these patients, disposition where they're discharged to, obviously length of stay and survival. Those are all secondary endpoints that we're looking at.
So you're conducting this study in Louisiana, which is becoming quite a hotspot for COVID-19. How could this rapid diagnostic help hotspot communities in this pandemic that we're seeing right now?
Yeah, Louisiana really has become one of the hotspots for this disease. And if you look at it per capita, we are probably in the top three or so with regards to states in the United States with kind of being affected by this disease. And actually, if you drill down in Louisiana, New Orleans and Baton Rouge are the areas where the predominance of these cases are. One of the things that we're hopeful for is that if we can employ this in our facilities and see that this assay, which can be performed in under 10 minutes, can provide emergency department clinicians with the information they need to appropriately triage these patients, determine who needs a more aggressive therapy versus determining who may need to go home. Then since we are kind of leading the country in this, as other communities begin to see more and more of this, we could deploy this technology to those communities and help them kind of avoid some of the burden that we've seen with regards to admissions of patients who stay in the hospital for just a day or two because we're concerned about what they may or may not have and then are discharged back. Resource utilization. The biggest thing that we see, the biggest problem that we have with regards to resources are really two. Number one, nursing and support staff. There just aren't enough nurses, and our healthcare providers do sometimes get sick. And so there aren't enough nurses and support staff to take care of the patient. So it's much better when we can to have a patient self-quarantined at home. And then the never-ending shortage of personal protective equipment that we have. Every patient that goes home and is able to self-quarantine is a patient that we don't consume at least 23 sets of PPE per day as the nurses are going in and out of their rooms to care for the patients. And so those are, I think, things that we could help the rest of the country with if we could use our experience here to educate and help technology and provide technology to help those other locations more efficiently move through their patients in the emergency department. I think that would be a huge win to the medical community overall.
Absolutely. Is there anything else that you want to add about your study or anything in general?
Yeah, I think the important thing to understand about the Cytovale assay that makes it a little bit unique with regards to this is that a lot of attention has been focused not only in COVID-19, but in other forms of sepsis that we see, is that there's been a lot of attention placed on early pathogen identification. A lot of technology out there in diagnostics of finding out what the pathogen is. That is not our intent, and we should not be confused with early pathogen identification. We are a test that assesses the host response. And so what we say is that we're about the patient, not the pathogen. We are looking at how the patient's host response is affecting that patient and how that response, that immune response, might impact that patient's outcome. We'll leave it to the pathogen identification experts to tell us what pathogen that is. But we feel that it's our job to appropriately risk stratify these patients, because it may be that if you have relatively mild disease and you can go home, it may not be necessary for at least treatment of that specific patient. It may not be necessary to find out what the pathogen is if they're going to be fine at home. Now, for epidemiologic purposes, I think that that's a different question, but at least with regards to treatment of the individual patient, we are looking at host response to determine if we can help the patient's outcome.
Fantastic. Well, Dr. O'Neal, thanks so much for taking the time to join me today. We really appreciate hearing more about your study, and we wish you luck.
All right. Thank you so much.